Hello, everybody, and welcome to Great Plains Quinn Friday Focus for Health Pathways to Safer Opioid Use. This Friday Focus for Health is hosted by the Great Plains Quality Innovation Network, the Centers for Medicare and Medicaid Services Quality Innovation Network, Quality Improvement Organization for North and South Dakota. My name is Carolyn Tufte. I'm a nurse by background and currently a Quality Improvement Advisor for the Great Plains Quinn. In previous weeks, you've heard from my colleagues, Carrie Sorensen and Stephanie Hansen, and next week you'll hear from Jennifer Lochner. Of course, we cannot go without mentioning Carrie McDermott as part of our team serving our communication needs. I want to thank you all for joining us today, and just a reminder, today's webinar is being recorded and will be posted within 1 to 2 business days on our website at greatplainsquinn.org under the Friday Focus for Health tab. And then Carrie should be dropping the link to that into the chat as well. If you have any questions throughout this webinar, please add them to the chat or feel free to come off mute and ask them. We have added a resource handout for you to access. This resource handout includes all of the resources shared during today's session and is being added to as the 4-week series progresses. We would really love your feedback on these weekly sessions and any ideas on future sessions. So please, at the end of today's session, complete the evaluation via the QR code you see here or the link that was just placed into the chat. We appreciate any and all feedback so that we can make these sessions more valuable for you. We've talked a lot about opioids and best practices with opioids. We have touched on how easy it is for someone to become dependent on these medications and have accidental overdoses. We've also provided education on reversing those accidental overdoses. But what can we do to help someone who is dependent on opioids and no longer wants to be? Medication-assisted therapy, also known as MAT or MAT, is an option, and this is what we will talk about today. What is medication-assisted therapy? Well, it's the use of medications in combination with counseling and behavioral therapies, which is effective in the treatment of opioid use disorders and can help some people sustain recovery. I want to share with you all this video. It's about 5 minutes in length, but it explains how these medications work effectively to help individuals with an opioid use disorder. I do want to make note that this video is 9 years old, so some of the statistics in it aren't exactly relevant, but the takeaway from this video should be how the medications work. I will bring it up.
The neurobiology of addiction.
Can you guys hear that?
Is a field that has really exploded over the last, let's say, 30 years. We are able to actually see what is going on in the brain in the addicted individual, the impact of the drugs that they are using on the brain, and then in some cases, the impact of some of the medications or pharmacotherapy that we use to treat their addiction. We can see improvement in brain function, which is very exciting. So as opposed to 50 years ago, when people thought that addiction was a problem of character or personality, or a criminal personality, or weakness of will, or other ways of looking at addiction, we really look at it as a neurobiological disease, or to put that in simple terms, a brain disease. We all agree that addiction is a chronic disease, that it has currently no cure, but excellent treatments, and that remission or recovery, which I use synonymously, are goals that can be met by many patients through a variety of different treatments, including pharmacotherapy treatments and non-pharmacotherapy treatments.
There's several different options available for people that are looking for medication-assisted treatment, and it really depends on the underlying condition that they're suffering from. If they have a problem with alcohol dependence, they may be looking at options like naltrexone or Antabuse. If they have a problem with opiate dependence, they may be looking again at naltrexone but they also might be looking at methadone or Suboxone. The naltrexone is actually a blocker, and it both blocks the high people get from alcohol when they do that, and it actually also blocks the high people get from pain pills or heroin. Methadone is what's called a full agonist. You can look at the receptors in the brain as a door, and a full agonist opens the door completely into the brain, which allows the full activity of an opiate. And so methadone acts as a replacement therapy for opiates. So if someone's in withdrawal from heroin or pain pills, that's going to allow the full activity into the brain to replace that. But the problem with a full agonist is sometimes people can also have negative effects. There's risks of overdose. Buprenorphine, naloxone, or Suboxone is what's called a partial agonist, and that's like opening the door partway. And by opening the door partway, you're actually able to let enough in to help with withdrawal symptoms and cravings, but not so much where there's a risk of overdose or people look sedated or out of it.
Most of the evidence shows that if there is a pharmacotherapy which has been shown to be effective and to help with that addiction problem, that the use of that pharmacotherapy, in addition to the use of a variety of psychosocial treatments, such as one-on-one counseling or groups, or going to a mutual help group like AA or NA, that the combination of the psychosocial treatments along with the pharmacotherapy will usually provide better results than either one alone. I like to use the slogan that all treatments work for some people. No one treatment works for everyone.
Often people are reading online, so often they have an idea when they come into the office what medication is going to work best for them. And we have a discussion about it. What's right for them involves a lot of there's basic differences between these different options, and they would have to evaluate those differences on their own and then talk to a physician about these differences and kind of find the right fit for them.
One of the most common misconceptions and myths by both patients, but really more often significant others, and again, the mutual help groups, is that when you take buprenorphine or you take methadone, you're just replacing one drug with another. And this is just not true, because we're usually replacing a short-acting opioid, which is generally causing damage to the patient's brain, with a long-acting opioid, which is meant to normalize and stabilize the brain. And we actually have data now to support the idea that methadone and or buprenorphine will improve brain function. It is very important for the patient and their significant others to understand that physical dependence does not necessarily equal addiction. Let's take a patient who's on insulin for diabetes. They must take their insulin every day. If they don't, they get sick. But nobody ever says that they're addicted to insulin. They just say they're on insulin, they have to take it every day.
If you develop opiate dependence when you're 20, there's a very good chance you're not going to live past 40. So I would say that's deadlier than diabetes. That's deadlier than thyroid disease. So plus the loss of functioning, even with thyroid problems, diabetes, people can often make it to work. They can often go to school. With people with active opiate dependence, they can't do those things. There's a complete loss of functioning.
It's easy to withdraw people over a week, but to maintain the abstinence from non-prescribed or illegal drugs, that's the challenge, and that's where these medications come into play.
Thank you for listening to this with me. My previous work brought me to working in this field of MAT, and he summarized so many things that we had to learn in lifetime the hard way very well. I do like his analogy between physical dependence and addiction. I think it's very profound how he relates that to a patient with diabetes. Methadone. In the video, one of the treatment options he mentioned was methadone. Methadone is available orally as a liquid concentrate, tablet, oral solution of powder, and a dispersible tablet. And we already learned that it's a full agonist. In this resource handout, there is a link to the regulations and certification requirements to become a methadone type treatment facility. These are called opioid treatment programs, and the process to become an OTP is time consuming, and as a result, OTPs are more common in urban areas. As a matter of fact, there are only 3 certified OTP programs in North Dakota: Heartview Foundation in Bismarck, Community Medical Services in Fargo and in Minot, And the Community Medical Services in Grand Forks is working on becoming certified. And there's only one OTP location in South Dakota, and that is located in Sioux Falls. Just some food for thought. I've put together a list of pros and cons to the use of methadone in a person's recovery. However, if anything else comes to mind, please feel free to pop them in the chat. I'm always welcome to expanding this list. So some of the pros are less risk of diversion, more accountability, and less risk of misuse. Some of the cons would be a person must present to the facility for the medication. The facility must be certified and maintain that certification of an OTP. And it's not a combination medication with Narcan like some of the other medications we're going to learn about are. And then there's less privacy, which increases the risk of stigma because you have to present to that specific clinic to receive your medication. Another option mentioned in the video is Suboxone or buprenorphine for treating opioid use disorders. This medication is a partial agonist and is available as a sublingual tablet, sublingual film, buccal film, implant, or intramuscular injection. Any facility can begin a medication-assisted therapy program if they desire, and this guide that I'm showing you on this slide will walk you through that process step by step. There's no certification required to do this. This provides you with dosing guidelines and best practices. This is also a useful guide for any existing clinics looking to review and update their processes. This was published in 2021 and is the most recent tool out there to my knowledge. I will say that this is a rather large toolkit. It can seem overwhelming, but as someone who has read it from cover to cover multiple times, every page of it is useful and it's designed to be a quick read. So when you open it, you're going to see that it's 90 pages, but in these next few slides, I'm just going to show how user-friendly this toolkit is. Within the toolkit, this shows how the patient moves through the phases of treatment with buprenorphine. And those phases are initiation, screening, agreement, induction, stabilization, and maintenance. It also describes what each phase is and how to know if you're in that phase. Within this toolkit is also a quick start guide, which takes a prescriber through appropriate dosing of buprenorphine. This is another page within the toolkit. The blue columns on the sides is education on what the patient might experience depending on what day of treatment they are on or the dose that they are receiving. This also includes a COWS scale, which as most of you know is a clinical opioid withdrawal scale. This is also helpful in determining the dose needed and if other medications are required to manage a patient's symptoms. The COWS scale brings me to this list of medication options that are safe to take while participating in an MAT program to manage any withdrawal symptoms or side effects you might be having. And then lastly, I just wanted to show that there is a checklist to use if you choose at each visit with your patients to ensure you're engaging in best practices. This toolkit also includes other resources like intake forms for nurses, telephone screening forms, a social needs tool, a printout of the DSM diagnostic criteria for opioid use disorder, and that's just to name a few. So it's very useful, although it's long. It's very useful. So again, I just put together some pros and cons for buprenorphine as a form of treatment for opioid use disorders. I would love to hear if you have anything to add to this list. So some pros are it reduces stigma because it is prescribed at a primary clinic. Individuals are allowed more privacy. You're going to the same place that I would go to for my yearly physical. The patient is able to take the medication at home, so they have an ability to have more flexibility and independence in their schedule. You know, they don't have to drive to that clinic every day. Maybe they can maintain working while taking buprenorphine or Suboxone. And it's safer because it does come with a naloxone combination, so it's safer for a patient to take. Some of the cons is there's a higher risk of diversion or misuse. And because you're not seeing that patient every day, like you would be with a methadone clinic, there's less accountability. You really they have to be accountable to their own self. Another interesting thing about buprenorphine is they are finding it's effective and safe and safer due to the naloxone combination in treating chronic pain as well. Naltrexone is the last option mentioned in treating opioid use disorder. Naltrexone is an opioid receptor antagonist and is available as a tablet and intramuscular medication. So this is an older medication. It came about in the 60s and it was found to block the euphoric effects of morphine. In 1984, the FDA approved it for the blockade of the effects of administered opioids. 1994, it was approved, naltrexone was approved for the use of in the treatment of alcohol dependence. And then most recently in 2010, the FDA approved an injectable extended release naltrexone for preventing return to opioid dependence after medically supervised withdrawal. Patients must typically wait 7 to 10 days after their last use of short-acting opioids and 10 to 14 days after their last use of long-acting opioids before taking their first dose of naltrexone. Despite its potential advantages, there's no abuse liability, there's no special regulatory requirements. Oral naltrexone is not widely used to treat opioid use disorder because of the low rates of patient acceptance, the difficulty in achieving the abstinence for necessary time before initiation of treatment. That's 7 to 14 days between your last use of an opioid, and high rates of medication non-adherence. So again, this is another lengthy document that I am providing you for opioid reduction, but the section on the medications gives you the patient handout information, the contraindications, the prescribing considerations, the availability. It's called a chapter on that, provides it for all of these medications back to back to back. So I wanted to provide that with you in case you are interested in only those medications. Referencing back to the video we watched at the beginning of this presentation, these medications are great and have helped make progress in the treatment of opioid use disorder, but medications alone aren't enough. MET programs are most effective when in conjunction with other types of treatment. And these are just some examples of the other types of treatment that are available out there. Individual therapy, family therapy, group therapy, medication, as we've talked about, and rehabilitation programs. How do we get access to these types of treatments? Any one or all of these professionals should be an integral part of a patient's journey to recovery. Medical doctors, advanced practitioners, psychologists, social workers, counselors and therapists, crisis support specialists, substance use professionals, and certified peer specialists. GP Quinn has shared both of these with you before, but they are worth sharing again and again. These are the links to the community resources for North and South Dakota. First link is the North Dakota resource, while Helpline is the South Dakota resource. Any individual, whether for professional or personal use, could utilize these resources to find a professional who could help with an opioid use disorder. So this can connect you to your counselors, your peer support specialists, your providers in your area. The Drug Addiction Treatment Act of 2000 created a data waiver, often referred to as the X waiver, to allow certain qualified practitioners to treat patients with buprenorphine outside of an opioid treatment program. Under this waiver, practitioners were subject to patient caps depending on the length of time they were registered with the X waiver. While the development of this waiver was a huge step in getting access to medication-assisted therapy to more rural areas, an even bigger change just happened. In January of this year, the DEA has announced that the X waiver is no longer required to treat patients with buprenorphine with opioid use disorders. This is huge. The removal of the X waiver Along with the removal of the need of this X waiver went the patient cap requirements. So this is really going to help generate access to MAT services, specifically buprenorphine. As with all high-risk medications, the risk of diversion is a concern. A contract or an agreement between provider and patient is always a good idea. These contracts should include the risk of taking the medication, expectations of the patient, expectations of the provider, and under what terms the relationship with the provider and patient will be severed. Examples of contracts are provided in the two toolkits that I referenced earlier. Urine drug screens are recommended to be performed at random intervals during recovery. A facility should ensure that they are monitoring for both prescription and non-prescription substances on these urine drug screens. This should be meant to be a tool to help promote and encourage how well a patient is doing throughout their recovery. Random pill counts is another intervention to ensure diversion isn't occurring. As a matter of fact, there are apps out there that are HIPAA compliant a facility can use to perform these. I have personally worked with Pill Count Pro app. This was developed by two brothers, one a provider for substance use medications, and the other one a tech developer who saw the need for such software and made it happen. Without going into too much detail, I will just say that I have personally worked with this company. It's very user-friendly, and they do a lot of the legwork for you. And I don't think we can go through all of this talk about opioid use disorders without mentioning mental health first aid. Just as people are first aid certified across the country to improve health outcomes by having more access to first-line interventions, the same is being offered for mental health challenges. This is a flyer of virtual classes offered in North Dakota. We will also drop into the chat 3 options to register for mental health first aid classes if you are interested. The first will be for the virtual classes that you see listed here, and we are adding more dates throughout the year to be offered. The second is for in-person classes offered in North Dakota, and the third is for classes offered in South Dakota. And then I encourage you to share these classes widely with your colleagues. This is just a recap of the resources and tools we mentioned. And so I will open this up to office hours. If there's any questions or discussion that anyone would like to have, please drop it into the chat or come off mute. Although I did get a little bit wordy.
I'm not seeing anything yet, Carolyn, in chat. Someone did ask, they weren't on their computer or they were using their app from their phone, but Carrie McDermott did respond to that and said the resources are available. So we did respond to that one.
Okay. Well, I have about 7 minutes left, so we could move on to, if you're interested in joining our community coalition listserv, this is the link to do so, and I would encourage you to do that just to continue to receive more information as it is being put out. And then I'll also just touch base on our April Friday Focus for Health series. It is going to be on the American Heart Association Life's Essential 8. And it is Tools for Optimal Patient Resident Health. This will occur Fridays in April from 12:30 to 1:30 Central Time. And you can register for this by visiting our Friday Focus for Health page. And then I will just put the QR code up here again. I have about 6 minutes left in this meeting, so I'll leave the QR code up here. I'm going to thank you guys all for attending, but I do want to be mindful of your time. So I will stay on if you have any questions. If not, please complete the evaluation and we will see you next week.
Thank you, Carolyn.
Thanks, Carolyn. That was excellent information.
Yeah.
And I guess this is Carrie. I'll just point out, Carolyn just shared our April series topic. Most of you are aware at this time, we have 2 topics that we're doing back to back on Fridays. And we've just made the decision to pilot a new model and strictly focus on one topic in April. And as she mentioned, it'll be the American Heart Association's Life Essential 8 resource or guidelines, I guess. And you can register on our website. And Selena, I will follow up from this meeting with an email to you with the presentation today and the resource list. All right. If anybody has any questions, you can put them in chat. Otherwise, I think we can probably end today's meeting. Thank you so much, Carolyn.
Yeah, it was my pleasure. I could have gone on and on about medication-assisted treatment.
There's a lot of information, but you just really summarized it well, and I think, gave everybody a good resource to look at and utilize, and I think you touched on a lot of great information, Carolyn.
Well, happy Friday. Have a great rest of your day.
Thanks,
Thank you.
everybody.
You bet.
Thank you.
Thank you.